Hello, everyone. I want to extend a warm welcome to the 2021 Pacific Northwest Palliative Care Summer Series, hosted by the Cambia Palliative Care Center of Excellence. I'm Theresa Braungardt, Senior Vice President and Chief Nursing Officer for UW-Medicine Valley Medical Center, and served as this year's conference co-chair along with Dr. Rashmi Sharma. Many of the talks to be delivered over the next 8 weeks were originally scheduled for our canceled 2020 conference. The intent of this summer series is to revive our efforts and to bring together those on the forefront of serious illness to foster learning, inspiration, and hope, and continue to provoke conversations that matter. I am honored to be with you today to provide perspectives from my nursing experience in critical care. Prior to my role at Valley, I worked at Harborview Medical Center as a nurse and subsequently nurse leader for both the medical and neuroscience intensive care unit. Over the years there, I had the great privilege to experience how the integration of palliative and critical care benefits our patients, their families and loved ones, and improves the resilience and well-being of all clinicians working with people in crisis, not only physically, but in very emotional and highly traumatic psychological crisis due to unexpected, unanticipated illness or injury. In my current position, I collaborate with clinical leaders throughout the continuum of care, from advanced care planning to end-of-life communication and decision-making, to help improve the patient and family experience, and am a champion of integrating palliative and medical or curative care wherever we meet the patient in their healthcare journey. I work in collaboration with our palliative and critical care teams on advancing the concepts of palliative care and implementing tools that help our clinicians address our patients' and families' palliative care needs. But today, I want to share why I'm so passionate about palliative care and what fuels this passion for me. In my previous leadership roles at Harborview Medical Center, I had the privilege of working with Dr. Randy Curtis and other clinicians on the agenda today. And I would like to take the next few minutes to share with you what I have learned throughout these experiences and address why developing palliative care skills is so important, and why it's especially so important for nurses to have input into the multidisciplinary plan, and some brief comments on how the pandemic highlighted the need for excellent palliative care and the challenges our teams experienced when families were unable to be physically present with their loved ones. For my nursing colleagues, I can't stress enough how important it is for nurses to have an active role in palliative care and to build skills in this specialty. In March of 2017, the American Nurses Association and the Hospice and Palliative Care Nurses Association presented a call to action for nurses to lead and transform palliative care. The recommendations included the adoption of End-of-Life Nursing Education Consortium as the standard for primary palliative nursing education. It is the unique position we have with our patients that make this call to action an imperative in providing holistic, patient-centered care. I believe our nursing education programs must move to include this knowledge area in all standard curriculum. One of the primary reasons is that nurses spend the most time with the patient and their family. Because of our constant presence at the bedside, we are in the perfect position to gain a greater understanding from the patient and family perspective just simply by spending time and building a trusting relationship. The nurse can gain information to inform the multidisciplinary team simply from what we hear, what we see, and understand from being at the bedside. And we are really good listeners, and we often field the questions families are afraid or intimidated to ask doctors. Nurses may be the first person the patient or family opens up to about their questions, their needs, or their goals and wishes, just because of the time we spend together. Nurses have a unique ability to extend their empathy coupled with their caregiving skills that allow them to build trust with the family and the clinical team. The better equipped we are in addressing their questions and bringing them forward to the multidisciplinary team, the more effective we can be in advocating for our patients. For these reasons, nurses have the unique ability to provide valuable and contributions to the multidisciplinary team in helping to achieve the best communication, and ultimately outcomes for our patients. But there are other reasons why developing palliative care skills is so very important at the most basic human level, and that is for our own health and well-being. In a recent AACN webinar series, that's the American Association of Critical Care Nurses, the recognition of moral distress evidence suggests that of all threats to nurses' well-being, moral distress is the least understood but the most detrimental. Moral distress has been described as knowing the right thing to do, but face constraints that make doing it nearly impossible. This conflict threatens our core values and moral integrity that can lead to nurses leaving the profession altogether. Nurses encounter many people experiencing life-limiting disease or illness for which they potentially have not had meaningful discussions regarding their goals of care, quality of life, or participated in shared decision-making with their family or surrogate decision makers. Furthermore, most surrogate decision makers are unaware of the wishes of their loved one, which makes it even more difficult to know what to do. We witness the suffering of people at the end of life, and at times this burden is felt by the fact that we are contributing to that suffering, and further may feel that we are taking part in futile care. Many deaths that occur in the hospital setting, especially in the ICU, involve decisions to withhold or withdraw life-sustaining measures. Again, nurses experience the burden of feeling they are contributing to suffering when these decisions are delayed for days or weeks on end, and this can result in feelings of moral distress. Family and physician communication around these decisions is still a major source of family and nurse dissatisfaction. Nurses witness inconsistent messages from attendings and other consulting specialists with families that make it more confusing for them, and often they are left trying to answer questions to account for these differences. The emotional toll this can have on nurses varies from psychological symptoms of anxiety and depression to feelings of helplessness, and can also manifest in physiologic symptoms such as nausea, migraines, GI upset, and inability to sleep. This can also ultimately lead nurses to leaving the bedside altogether. I experienced this wide range of emotional trauma myself as a bedside nurse, and later as a nurse manager. It was also a source of moral distress for me as a leader. I could see our nurses needed help in understanding and navigating these feelings, but wasn't sure of the course of action to take and to help them. It wasn't until our team in the medical ICU started working with Dr. Curtis in the early 2000s on advancing the concept of palliative care into our multidisciplinary rounds did nurses start to fully understand how they could incorporate palliative care tools and concepts into their practice, and how this could make a meaningful difference in their daily work. We also got to be involved in developing and testing order sets supporting the physiology of the withdrawal of life support. And back then, honestly, we weren't very good at it until we learned to understand that withdrawal of life support is a procedure that has a process and a method that can result in a peaceful death filled with dignity and compassion. Not to confuse palliative care with comfort care or end-of-life care, which happens all the time, but the palliative care research and resulting symptom management really improved and informed how withdrawal of life support was managed. This work became a source of great relief and a source of empowerment for nurses. It not only benefited the patients and families we were serving, but also the well-being and morale of the entire clinical team. Witnessing suffering and death is part of our calling, but knowing that we are part of a team, supporting each other and working together to provide the very best care, whether it is at end of life or developing goals of care, eases the burden of facing what we all may experience at some time in our life, and that is a serious illness or disease. As clinicians, one of our greatest gifts we can give is to assist people and their loved ones through their decision-making process when faced with a life-limiting illness and ultimately to aid them through a death that honors their wishes and those of their family. This work, though, can take a great toll on all clinicians and increase their risk of burnout and decreased emotional well-being, and contribute to a lack of resilience. As a nurse leader, my role is to help give nurses the tools to aid them in their work, take good care of their physical and emotional well-being by learning how to manage difficult conversations, by utilizing the concepts of palliative care, and that is what fuels my passion to this day. Because I witnessed firsthand how this work changed everything about the way nurses felt about how they could contribute differently in these daily conversations. It gave them the tools to discuss the needs of the patient and family. In fact, one of the first tools we started using on rounds was the Discuss tool developed by Dr. Daryl Owens, currently the director of the Palliative Care Service at UW Medical Center Northwest Campus. This tool provided our clinicians and anyone who wanted to use it the questions and words about how to bring up the benefit of palliative care for their patient. At that time, nurses did not formally present on rounds, so we had to be courageous to bring up what was then a relatively new topic. Our leadership team supported the nurses because not all attendings were comfortable with these conversations. That was to be expected. But slowly the culture started to change, and the changes I saw most were in our nurses' ability to manage difficult conversations, to bring forward important family issues and concerns, and feel confident they were doing the right thing for their patient, their loved ones, and very importantly for themselves. Those feelings of helplessness were no longer there, or were at least lessened. And for this was life-changing. And that culture continues to evolve today. As more research is done, new practices are put into place, and more clinicians improve their primary palliative care skills. In closing, I'd like to touch briefly on the challenges of facing moral distress during the COVID-19 crisis. The early stages of the pandemic created unprecedented challenges on the front lines of care across the continuum, including insufficient supplies of personal protective equipment shortages overall, compromised staffing and resources needed to care for patients, especially the critically ill, and balancing our own professional duty and responsibilities with our personal safety. Although we are still learning and understanding what this past year has meant to all of us, the emotional toll is something exponentially more traumatic than anything I've ever lived through in my 32 years of nursing. As a result, many healthcare providers are experiencing moral distress that has been prolonged now for over a year. None of us have lived through a time where there existed so much uncertainty about what was to come, so much so that we could not allow family members to be with their loved ones. I cannot think of anything more horrifying, isolating, and just so unbelievably hard for our caregivers to live through. And I have never witnessed so many tears as we have this past year. Each member of the clinical team became the family of the patient. Even with the virtual methods and technology, nothing can replace the presence of human connection and interaction at the time of death. Our caregivers became that only source of connection, and in many ways still are today due to the isolation practices required for the care of COVID-19 infections. Leaders in the critical care unit worked very hard to acknowledge these feelings at each shift huddle, to allow space and time to talk about how everyone was doing, knowing that every one of us is facing loss, to include a moment of gratitude at the beginning of each shift, and implement critical debriefings to acknowledge that we have not failed, we have done our best, and we made a difference. Through this challenging time, we have improved our moral resilience. I know everyone attending this conference today is as passionate as I am about these topics, or else you wouldn't be here. We all want to learn how we can make a difference, how we can improve our practice, and ultimately take the best care of our patients and ourselves. I hope that the concepts shared in this series will help you change and improve your practice and will help in healing the wounds we all carry as clinicians working in this most amazing and fragile space. So now, here to kick off our summer series is Dr. J. Randall Curtis. Dr. Curtis is a pulmonary and critical care physician at Harborview Medical Center at the University of Washington. He also holds the A. Bruce Montgomery American Lung Association Endowed Chair in Pulmonary and Critical Care Medicine, and he is the founding director of the Cambia Palliative Care Center of Excellence at UW-Medicine. He has an active research program with over 25 years of continuous funding focused on improving palliative care for patients with serious illness as well as for patients' families. Dr. Curtis is a champion for timely integration of innovative research and quality education into the healthcare system. I am so honored to have been involved in a small part of his work and also to call him a friend. His research has taught us so very much about how to improve family communication and given us the tools and data to provide the very best care for those facing serious illness to choose their path. And now, please join me in welcoming Dr. Curtis in his talk entitled Promoting Serious Illness Communication at UW-Medicine, Using Research and Education to Improve Healthcare. Thank you.